Good morning and good afternoon. My name is Sarah Richter, and I'm a volunteer moderator of MAVEN Project, and I welcome you to today's session on medication non-adherence, Understanding Your Patients and Improving Outcomes by Dr. Fred Kleinsinger from the partnership with MAVEN Project and Direct Relief. It is my pleasure to introduce you to today's speaker. Dr. Fred Kleinsinger is an assistant clinical professor, family and community medicine at the UCSF School of Medicine. He retired in 2008 after practicing medicine for 38 years. Although he initially practiced at community medicine clinics and in a private practice for 5 years, for the last 13 years of his practice, he was a physician in the medicine department at the Kaiser Oakland Medical Center in Oakland, California, where he was an assistant chief of medicine. Please mark your calendars for the following upcoming presentations with Direct Relief: Pharmacological Treatment of Anxiety Disorders on April 23rd, 12 p.m. Pacific Time, 3 p.m. Eastern Time. Conversations with Challenging Patients, 12 p.m. Eastern Time on May 9th, and June 4th, 11 a.m. Eastern Time, Transgender Adults Guidelines and Update. And with that, Dr. Kleinsinger, I'll have you begin.
Okay, well, hello, everybody. Good morning, if it's morning for you. I'm going to start off by telling you the whole presentation in about 4 sentences. So if any of you are in a real hurry, you could just listen to this and leave. But I think you'd learn more if you stay for it. In essence, what this is about: one, we in the profession underestimate the extent to which our patients are not taking their medicines. It's an epidemic. It's not endemic, it's an epidemic. And we'll go into more detail about it. Two, we don't appreciate the fact that a lot of times when people's chronic illnesses are not being well controlled, it's not because we're not doing the right things, it's because the patients aren't taking their medicines correctly. Three, it's our responsibility, in my opinion, as a profession, to be more aware of this and to look for it, to deal with it, and to help patients with it. And four, we're going to talk about techniques for both identifying non-adherence and also how we as individuals and working in clinics can do this. So that's the entire presentation. If you want a little more detail, stay here, okay? Also, I like people, even though I'm not seeing the chat, I like people to raise questions and stuff or comments and things during the presentation. My long experience is that if to any degree that we can make this Zoom stuff interactive, that it improves people's interest and success of the presentation. So I've asked Sarah to monitor the chat and to let me know. Sometimes if you come up with a question or comment, it's going to come up later and I may just say that, but I do like interruptions of that sort. Okay. And that's my main introductory stuff. So anyhow, medication non-adherence. Is this something that happens occasionally? We do a good job and the patients, we just have some patients who just aren't very good at being patients and they don't take their medicines, but usually it works really well. And why is this an issue? That, by the way, is the dominant feeling in the medical profession about this problem. Or is it an extremely common outcome in treatment of chronic diseases? I wrote down a few here: hypertension, diabetes, dyslipidemia, but the same statistics when it's studied apply to COPD, psych disorders, endocrine disorders, et cetera, et cetera. People just don't like taking medications, though it's more complicated than that. So the goals, as I was saying that at the beginning: understanding the frequency and consequences, causes, diagnosing, improving. And my other introductory comment is that I do these presentations not just to entertain people. I hope I can be an entertaining presenter, not just to be gratified by having someone read my little bio on the screen. I want this to affect how you practice medicine. I want you to look for anything you find valuable in this that you can apply to your own practices. And then if you find anything valuable, write a note, post it on your computer, do something like that. So that remind you, and then the next time you're seeing patients, I know this is Friday, if you're seeing patients on Monday, try and use whatever seemed valuable to you, because the literature on medical education in general says use it or lose it. If you don't find things that you find valuable and start using them, it becomes something in the background of all the other 18,000 things that you're dealing with every day. So that's my request of you, okay? Look for something that you find valuable, because I hope to make the point that this is an extremely important topic that is very much underappreciated and dealt with. And I just said that already. I won't go it over again. How will I change my practice based upon what I'm learning here? So anyhow, defining compliance. By the way, the terms compliance and adherence are somewhat interchangeable. The compliance has sort of gone out of style in the literature because it sounds a little authoritarian, like, comply with my recommendations kind of stuff. But adherence, which is not a great word either, makes me think of glue. But anyhow, that's the current term. So, and also in terms of nomenclature, I have a tendency to say doctors, and when I mean clinicians, and a lot of the work I've done with MAVEN is primarily with nurse practitioners and physician's assistants as well as doctors. So please, and I don't like the word provider particularly. It sounds like something that the people with the MBA degrees like to use. So if I'm saying doctor, I mean all prescribing clinicians. Okay. Anyhow. Defining compliance is taking 80% or more of one's medication. That's what's in the literature. What percentage of patients succeed in meeting this target based upon a recent meta-analysis? Does anybody want to take a stab? Okay, well, I won't spend more time on this, but 60% is the number that comes out in most studies. And you'll notice that this particular thing I quoted is from 2008. I've been writing and teaching about this topic since then. And I have to say, even though this is an old study, the most current studies show no improvement in this, that we're deluding ourselves. Somewhere around between half and 2/3 of the medication of the patients we're seeing are taking their medicines regularly. The rest are not. So rates of medication adherence drop after 6 months. Only 51% of Americans, this is not treated for hypertension are adherent to their long-term therapy. By amazing coincidence, I have to try and understand if there's a relationship here. Community hypertension control rates for people who are being treated for hypertension are in the 50 to 60% range. And there may or may not be a connection there. Anyhow, and talking about statins, about 25 to 50% of patients who are taking statins discontinue them within a short period of time. Now, this slide I made up because the statistics are poor, okay? But there is some indication in the literature, which has not been well studied, that approximately 125,000 deaths a year due to medication non-adherence. In other words, we have tools for treating these chronic conditions. Like, I'm going to use hypertension and diabetes as my main examples because they're the commonest. We know from the literature that treating these successfully reduces the rate of complications and decreases mortality. And so when people don't take their medications, it's wasting a lot of medical effort. It's also leading to increased hospitalizations, billions of dollars a year of increased healthcare costs, and many deaths. Now, take where I put this on this list of leading causes of death, because I'm not sure that number is good. But if it is good, it means it's the 6th leading cause of death in the United States. It may be the 5th, it may be the 8th, but it's up there. And as I say, very much underappreciated. Now, there are, for a lot of other conditions, there are advocacy organizations like the American Heart Association, American Lung Association, whatever, but there's no American Medication Non-Adherence Association. I consider this to be an orphan problem. In other words, no single entity has taken this on. The specialty organizations have not, like the American Diabetes Association has not particularly taken this on well. The American College of Physicians has not taken this on well. The American Academy of Family Physicians has not, ... No one's taking this as seriously as I think it should be. And partly because it's a multifactorial, interdisciplinary thing that does not fit easily into how we like to view medical issues. So I've done a long slide here. Since developing this, I took a class on developing good CME presentations that said, do not make complicated slides, okay? But I like this mostly. I'm not going to dwell on it, but when you do look at the literature about adherence, you often find lots of reasons that the profession comes up with why people are non-adherent. And these all have some degree of validity. And I'm going to run through them very quickly. This is not to memorize, just to see that. And after doing this slide, I'm going to criticize it. But motivation, health literacy, cost, time, alternate belief systems, treatment of asymptomatic disease, poor privatization, inconvenience, depression, denial, cognitive impairment, drugs or alcohol. We're going to talk about some of these more because they are important. Complexity of treatment, side effects, and cultural issues. We are going to talk about these things. I take them seriously, but it's not the whole picture. Because from my perspective, from the perspective of the literature, inertia rules. Changing human behavior is difficult, much more difficult than we understand. If we underestimate the difficulty of that, we act like the way we usually do business is effective, we're going to miss the problem in dealing with it. Now, there are many studies. A lot of the literature is focused on barriers to adherence. That approach that I just listed a lot of the barriers in 2 slides ago, that approach assumes that adherence is the norm and that if you're not adherent, if patient's not adherent, that there are various obstacles that can potentially interfere with this process. I'm not saying there's no validity to this. I don't think there's much validity to it because of the fact, in my perspective, are these obstacles or are they excuses? To the extent that we in the profession are aware of it, we tend to blame the patient. Like, hey, I did my job. I diagnosed hypertension. I told them they better take their medications. If they don't, they can have all sorts of complications. They can have whatever, kidney failure and, heart attack or death, et cetera, et cetera. So if they don't do it, that's on them. But a new understanding is that change is an active process, not a simple process. It's multifactorial. Helping people with change. And it's not just about medication. We in the profession aren't particularly good at people making even more complicated changes in their lives. For those of you who have recommended that somebody lose weight or something like that, or exercise more, or eat a healthier diet, I know you know that that's difficult to do, and that I'm really suggesting that people do that doesn't work particularly well. We in the medicine field tend to trivialize the fact that taking medications, we are used to doing it. We prescribe it. Why don't people just do it? It's not hard. You get a little bottle, you stick a pill in your mouth, big deal. But the literature shows that success in any change, including medication, requires education, understanding, motivation, tools, monitoring and evaluation, and feedback. And we're going to talk more about all these things. It's not as simple as we'd like to think. And it's going to be more time consuming than the traditional way of doing it. And as soon as I say time consuming, half of you are going to, tune me out because I know that you don't have enough time in the day to do what you're already doing. I know that. So for adherence to be successful, the patient has to feel that the benefits of it exceed the difficulties. Now, how are they going to get to that place? Question for the group. We're going to come back to that. How do we as clinicians assess adherence? Do any of you want to put something in the chat about that?
Right, nothing in the chat so far.
Okay, if you come up with something, okay, great, we're getting things. Lab results with the normal vitals, excellent. If someone's treated for hypertension and they come in and their blood pressure is controlled, great. And the corollary is true. If they come in and their blood pressure is not controlled, it could be because the other things are going on, but it's often due to the fact that they're not taking medication. Tracking lab values over time, absolutely right, particularly for diabetics. Pharmacy, yes, to those of us who have access to patients' pharmacy refill records. I worked for, as Sarah said at the beginning, for Kaiser for most of my life. Most of my patients got their refills at Kaiser, so I could look when I'm seeing the patient and see when they refilled at last. Results on labs and measuring BPs, last refill date, yes. Have patients bring bottles. Oh my God, you don't need this presentation. You're great. Bring bottles and check it. Yes. Talking to the patients about their medication and how they're taking it. Yes. And we're going to talk a little bit more about this. This is great chat. Thank you so much. So the 2 main principles, always be alert to the possibility of non-adherence. As I hope to make the point, this is not a rarity. It's extremely commonplace. Ask open-ended, non-judgmental questions about adherence. By the way, anytime you're dealing with a potentially difficult topic with patients, open-ended, non-judgmental will get you better answers. We'll talk about that more. So Compare these two different questions. Oh, by the way, I'm going to be talking some about worse and better ways to do things. The worst ways to do things pretty much all come from my own practice, okay? And from practice I've observed with other people too. That we don't often ask questions in the best way. For example, I'm in a hurry. You take all your medicines correctly, right? Good, okay? Versus, how many doses of your medicines do you miss taking in an average week? The difference is that we're normalizing that. We're not judgmentaling it. We're acting like this is not a rare thing. We're not going to shame you. We're not going to yell at you. We're not going to guilt trip you. We want to know. The questions like that work better. And also, I'm going to add, it's not on the PowerPoint, but my favorite communication tool that we have as clinicians, our best communication tools are not in the front of our face, okay? Our best communication tools are on the sides of our head. And we don't do that enough. We don't listen, as maybe many of you do, and you're better at it than I was for a lot of my career, but we don't listen to patients enough. Listening is how you really understand what's happening, and we're going to talk about that. So, red flags regarding non-adherence, and people of you who put this in the chat already did a great job. Many missed appointments. Unexplained poor control with ordinary medication regimens. Now, there are lots of reasons for medicines not to work, but non-adherence is a big one. And if you're prescribing hydrochlorothiazide or lisinopril or an ARB for hypertension and a usual dose for someone with mild hypertension and they're not budging much, that might be a reason. Vagueness regarding medication. I have these blue pills. I take them every day, et cetera, et cetera. Inconsistent monitoring. Someone who's been using a blood pressure cuff or using a glucometer, and all of a sudden they don't bring it in with them, or they don't bring their results. I'm going to be red flagging myself some of the most important parts of this presentation. I put this one in cap. Before you add a new medication, do your best to make sure they're taking their existing medications. We have a tendency in the profession that if we prescribe hydrochlorothiazide 25 milligrams a day mild hypertension, they come in 2 weeks later, 2 months later, and it hasn't improved much. With that, let's add some, Cozar, let's add some lisinopril. Oh, that isn't working. Well, maybe we'll add some calcium channel blocker. Before you add, do your very best to make sure they're actually taking, because we get the loop. Now, these days we have electronic health records of varying degrees of quality, but the EHR can help us to the extent that you can review medication refill records either on your side, on the pharmacy side, or both. Review lab and other monitoring studies. That's very helpful. Someone's A1C has been 6.8, 7.2, 7.0, 8.3. They haven't gained any weight. That's a red flag. Review visit frequency. Someone's been coming every 3 to 6 months, then you don't see them in 2 years. We're going to talk about that. Ask patients to bring medication bottles or lists to appointments. That could be very, very helpful. My favorite anecdote about this is that I asked the patient to do this, and they were very adherent to my recommendation. They brought their medications in. This is a true story. It was a paper bag. When I looked at the bottom of the paper bag, there were about 150 pills of all different sizes, shapes, and colors, all mixed together. That was actually a very important clue to me that they weren't taking their medicines at all, because how can you do that? Anyhow, but I really recommend that. Okay, so those are how to be a detective, how to recognize non-adherence. Now, why is this an issue for us? It's on them, right? We've prescribed. Okay, the old paradigm. We as clinicians, our job, you have diabetes, your A1C is 7.3, your fasting sugar is 154 on 2 occasions, you have diabetes, okay? So you have diabetes. So this is a serious disease. Good news, we have treatment for it. You need to lose weight, you need to exercise more, you need to stick your finger a few times a day, you need to avoid sweets, you need to start taking this medication regularly, you need to, et cetera, et cetera, et cetera. Any questions? Okay, fine. Come back and see me in 3 months. That's the old paradigm. By that paradigm, we've done our job. We've explained it to people. We told the risks of being non-adherent. And if they don't do it, well, the people are funny. Not my problem. Okay, that's the old paradigm. The newer paradigm, which clearly I'm endorsing, is that diagnosis and prescription are the beginning of our responsibility, not the end. That to increase adherence, and again, I'm not just talking about medications, any adherence to medical recommendations, patients have to understand why it is in their interest in a way that is meaningful to them and why to do this. And I say here, and different patients need different levels of explanation and understanding. How do we know if patients are understanding? Well, we're going to come to that. Really important. But it has to be, and one size does not fit all. The explanation you give to, I had patients in my practice who were law school deans, and I had patients in my practice who were bus drivers, and I had patients in my practice who were unemployed, disabled, on Medicaid, et cetera, et cetera. And the principles of education for all these people are the same, but the way we do it has to be different and tailored. Okay, we're about to come to number 2 most important points. This is the actual most important point of the entire presentation to me. The doctor prescribes, the patient decides. They decide. Then later on, whatever. We have to help them more than we traditionally do as a profession. I'm not criticizing any of you individually. Some of you very likely are really good at this, but we have to help people make good decisions. And so we're going to come back to that. Now, I'm bringing up the issue of cultural issues in compliance and want to say that basically that this is a very complicated issue and I can't do justice to it, but I want to raise it because when I say culture, I don't just mean, well, I'm Hispanic American, I'm Caucasian, I'm from Pacific Islands, but that culture of the culture we come from, and there are many, many subcultures, affects our understanding of disease, attitudes towards treatments, complementary medicine, communication styles, really important one. Different cultures, different communication styles work better. Now, when I say this, I'm stereotyping because we can have 2 people who are from the exact same background, grew up the same place, have the same educational, socioeconomic status, who have very different attitudes towards these things. So we can't stereotype too much, but there are some general issues to think about this. And language issues, really, really important. Working through interpreters is good. It's nice to have it, but you're missing a fair amount that way, and that makes it more difficult. The bottom line is that the greater the cultural gap between the doctor and patient, the more likely that cultural issues may be playing a role here. No guarantee of it, okay? So, and in patients from some cultures, have a historic and currently understandable mistrust of the medicine in the medical profession. And I'm getting into DEI stuff now, and I hope that the powers that be aren't listening. I don't want to end up in jail for bringing this up, but this is very real. I bring up the example of the Tuskegee experiment. There are many Black Americans who do not know much about medicine, but they know that back in 30, 40, 50 years ago, in the 1970s, that African-American patients with syphilis were deliberately not treated to see the effect of it without knowing what's going on. The Tuskegee experiment, this is in people's conscious or subconsciousness, even if they don't know the details of it. And also, let's face it, structural racism, misogyny, and socioeconomic bias all play a role here. The medical profession does have all those things in it. And I'm not talking about people being bad people. This is it's in our implicit understanding of the world, and we have to be aware of it and try and deal with it. But I'm not going to, that's a whole new topic. So, and these issues can be especially prominent in safety net clinics. And you know this, patients are often poor. They have in their own lives been subject to racial discrimination and other forms of prejudice, and they often lead more chaotic lives. So we in the safety net clinics have particularly responsibility for this. But I didn't say this before. The studies based upon adherence that I was quoting earlier about the 60% adherence levels are mostly done in insured practices where people have medication coverage and can see doctors. Imagine how much worse it is when you're not in an insured practice, et cetera, et cetera. So anyhow, some issues to look for with when you're recognizing non-adherence. The 4 Ds. Depression, we all know depression is extremely common. It's often underdiagnosed. And studies continue to show that for reasons that probably are obvious, to all of us that depressed patients are less likely to take medications. What can you do about it? Just have a high recognition for the fact that depression is common. If you have any suspicion of it, ask about it. If those of you who are familiar with the screening questionnaire, the PHQ-9, that patients can do this themselves, and I can give you cues and asking about it. The PHQ-2 is very valuable. Do you feel depressed? That's 1 and 2 questions. And are you enjoying things in life the way you always have? Now, that's looking for anhedonia. You can ask that very quickly, and if you get answers that are concerning to you, you can go hone in on that much further. But we do not recognize it. Patients don't like to bring it up also. Denial, okay, really, really common. It's a common defense against stress and adversity. It can be beneficial. Okay, what's beneficial denial? The example I just moved, by the way, so the example I'm going to give is not a great one. Until 3 weeks ago, I lived in the Oakland, California hills. My house was a 1/4 mile from the Hayward Fault, which is one of the major faults in California. And I lived there for 40 years. Did I spend all my life worrying, is there going to be an earthquake tomorrow? Well, I did seismic retrofitting to my house, and I got earthquake insurance, and I decided, well, I'm not going to worry about this. I'm not going to move based upon that. And I put it out of my mind, which was functional. That's beneficial denial. Detrimental denial is when you put things out of your mind that you do have options to, that you do need to deal with. And we in the medical profession unfortunately, we can strengthen detrimental denial. Fear can strengthen denial. And by the way, if you're concerned about denial, you can raise that with patients. Again, bringing up any tricky topic, you want to normalize it. As a lot of my patients have trouble really, keeping in mind the fact that they have a chronic illness. They use a technique called denial, which I understand. You don't want to sit around being stressed all the time as long as it doesn't interfere with your quality of life and your care. Now, do you think that might be going on with you? Now, why do I say fear can strengthen denial? And this should be obvious to you. When we first introduce, you have hypertension. The importance of treating hypertension is not just the number, that poorly treated, undertreated hypertension does have serious consequences. It can cause, et cetera, et cetera. I'm not going to go over the list, but we often give a long litany of it. That's fine if we do it in a calm and informative manner. But when the patient comes in and their blood pressure is too high, we think our next tactic is to strengthen the warnings. Don't you know that if you have blood pressures in this 160 over 110 range, that you could have heart attack, you could have a stroke, you could have kidney failure, you could end up in the hospital, you could have premature death? Don't you understand that? Well, we may be feeling that, but we say that patients are frequently going to be tuning us out because we're strengthening their denial, their negative denial. So we don't want to attack people with a sledgehammer of negative things. We want to inform them of it in a gradual and peaceful way and not scare people. Scaring is not particularly good in the medical profession. Okay, dependence. We all know and unfortunately in safety net clinics, these are big problems. Any clinic, they're problem. Alcohol or drug dependence are extremely common. Either can interfere with treatment. Consider asking non-adherent patients, take out non-adherent, ask all patients about alcohol or drug use, normalize it. I ask all my patients this. I'm not focusing you, but do you drink alcohol at all? Oh yes, you do. Go on from there. Or you don't use any of those nasty drugs, do you? No. Which recreational drugs do you use? What's your favorite recreational drug? Those are all good questions to ask. I have done people in their 70s and 80s. Sometimes when I asked that of them in the past, they've given me the fisheye, but we're still worth asking anybody about it because, all these things are relatively common. Dementia. This is an important one. I got burned on this many times. A person I knew for many years, very pleasant, socially well-prepared. Hi, Dr. Kleinsinger, how are you? How are your kids? What have you been on vacation lately? Yes, very nice. Her blood pressure all of a sudden is going higher. Early cognitive impairment can be common, and we don't realize it. It's frequently not apparent, and it can impede in clients. So if you have any questions about this, there are some simple screening tools, which I'm not going to go over here. The mini cog, which takes about 2 or 3 minutes, or the MOCA, which is more complicated. These are the most validated of the cognitive impairment screening tests. The MMSE mini mental status exam takes longer, and it doesn't have the same sensitivity and specificity. The very quick mini cog exam is really good. Look it up. Okay, now we're getting to another part of the presentation. How do we improve? We've recognized, we've asked patients, we've realized for whatever reasons, we've been detectives that they're not taking medications appropriately, that their conditions are not being well controlled. How do we improve adherence? And there are multiple ways to approach it. One single approach at a time isn't that effective. A Cochrane study, I quote the one from 2014. There was another one just a few years ago, same conclusions. A multifaceted approach is most likely to be successful. Now, we're talking safety nets, so this is really important. Cost can be a factor. Studies have shown many American patients don't take their medications appropriately due to cost. And at one point, I was saying that didn't need to be that big an issue because most of the medications for common conditions, so pretty much all hypertensive medications are fairly inexpensive, but even what we consider to be fairly inexpensive can be expensive. So that's something for people who don't have much money. We have to ask about that. Why I'm changing my tune about this is that, as you all know, that there's a slew of new diabetes medicines, your GLP-1 agonists, your SGLT2 inhibitors, which are extremely expensive. Depending on which drug and dose, you're talking anywhere from $600 to $1,000 a month. So this is a big issue, and often insurance are not covering them well, et cetera. There are copays, et cetera, et cetera. So cost is a major issue, and it's worth asking about if you're seeing patients with non-adherence. And practical tips, how do you deal with cost? Not easy, but use generics whenever possible. Be aware of patients' financial responsibility, whether they can afford. Encourage use of low-cost pharmacies or generic some of the bigger pharmacy chains have discount programs for chronically prescribed generic medications. There's a website called GoodRx, which often has coupons for people. Now, at safety net clinics, frequently normal medications, average medications are included, but when that isn't true, there are tips you can use. And I don't know if you have Costco in your areas, but Costco sometimes has very good prices on that. And other issues, not besides cost. Using once daily prescriptions whenever that's feasible is best. We know from studies that anything above 1 a day adherence rates drops. Anything more than twice a day, unless you're dealing with somebody with obsessive compulsive disorder, they're probably not doing it. So try to avoid that. Encourage use of pill boxes. The weekly pill box is very helpful. As a reminder, you only have to set it out once a day, once a week, and not every day, and you have an immediate reminder. Oh, and Costco has great prices on meds, also dog and pet meds, somebody put in the chat. So if Fido needs a medication, okay. Pill boxes, you want to make a habit of it. Suggest taking pills at the same time each day, preferably associated with other habitual behaviors like brushing teeth. That works, an association. Lots of people brush their teeth. So if you can say, make it a habit to combine the two, then taking the medications becomes a habit too. And also you can get prescriptions mailed, which is much faster than having to go there online and deal with it. And your practice can also fill out PAPs. I'm reading this from the patient assistant programs for the different drug companies for those with low income. Really good point that I didn't think of. Yes, because of my Kaiser background. But yes, for some of the expensive medications, if you have low economic status and don't have insurance that covers it, they have very reasonable plans. So that's an excellent point. Thank you for doing that. Okay, now communication tools. We're going to talk about this. This is really, besides diagnosing and being aware of the frequency, this is the big issue here because my own feeling, and the literature supports this to its limited extent, is that poor or inadequate physician-patient, doctor-patient, clinician-patient communication is the root of some of the non-adherence issues. Now, shared decision-making. For those of you who are younger, you've probably been trained in this. My experience is that it didn't come into vogue until maybe 25, 30 years ago talking about this. In the old model, the doctor is the authority and prescribes in many ways what the patient's to do. In the shared decision-making model, the doctor and the patient collaborate to develop a treatment plan. And the first step is a mutual understanding of the nature of the problem, including the risk of the untreated, the undertreated, and the principles of successful treatment. The patient needs to understand this because it's when they are in the loop on this, when they grok this, to use an old phrase, they're much more likely to want to do it. You really want to get it to the point where it's not like, I want the patient to do this, but the patient says, doctor, you're not prescribing, I'm having trouble getting my medicines. What's wrong with you? Yes. You don't want them to have the problem. You want them to be banging your door down to get it. And various communication tools. This is the most important communication tool. This is another one that I want to emphasize. Teach back. I was sort of informally doing this, but when I started teaching at UCSF about 15 years ago, I learned this phrase. Ask the patient to teach you what they understand from the discussion. This is the best way. Instead of saying, is that all clear what I just said? No, say, how do you do teach back? Again, normalize it. Don't put patients on the spot. I know that what I just said was pretty complicated, and it's really important to me that you understand this and that I have communicated well. How do you understand? How did you understand what I just said about why we want to treat hypertension? And then communication tool, which is the mouth zipper. We sit back and listen non-judgmentally. And then they say, yeah, okay. I think a lot of that got through. One point that I don't think I made clear is ... So let's go over that one again, okay? Not that time consuming. Also, compared to the time consuming of the patient not being well treated, coming to see you more often, ending up in the hospital, it's a time saver. Teach back. This is how we understand if we're on the same page. Really important. I know you're doing it, but I wanted to give it a name. Anticipating obstacles. We've discussed the 2 or 3 things that we want to do. Now, I know that for many patients, they think, well, sure, I'll do this. But then when they think about it, they realize it could be hard for them. What might be difficult for you about this? What obstacles could stand in your way? Mouth zipper. Okay, those 2 things help. Also, it's very respectful when you do that. You're being aware of patients' lives, how they're feeling, the other stresses they're dealing with. Let them talk about it because you can then problem solve around it. If you're not aware of it, you can't problem solve around it. Another point, incremental approach. We in the profession are taught, we're graded often on how well we do this, is going through everything with the patient. Okay, so you have diabetes. It's very important to understand that the diabetes, if it's not treated well, can have many complications, including diabetic nephropathy, heart disease, diabetic retinopathy, diabetic neuropathy. So we want to treat all this and to treat. The understanding of a condition and its risks and the treatments often have multiple components. If you do too much at once, you overwhelm patients. And when you overwhelm patients, guess what they do? If they're anything like many of my patients or me, I don't get that easily overwhelmed, but I'm starting thinking about when they're droning on. I'm thinking, well, I'll get out of here in a half hour, and yeah, there's a really good hamburger place near. I think I'm going to go there. And they're nodding. Okay, don't ask people to do too many things at once. For patients with almost any chronic disease, if it's in a mild or early stage, they don't have to do everything at once. They can start one task at a time. So if you suspect or concern this may be happening, you say, there are a few things we might want to do for your blood pressure. Exercising more, reducing salt, reducing alcohol content. I'm going fast here, taking medication, but we don't have to do all these at once. Which would you like to do first? And then mouth zipper. And then again, if it's 200 over 130, maybe we don't have the luxury of that. But most hypertension, especially now that we've redefined hypertension to what used to be considered fairly low numbers, there's no rush about this at all. What would you like to do first? And then when this is successful, we add new treatment elements at subsequent visits. So, and the next slide goes along with that. We want to build self-efficacy. We don't want patients, the opposite of being overwhelmed is to feel competent and that you have self-efficacy. And success begets success. And the converse is also true. If we overwhelm patients, they're less likely to follow through. So patient comes in, their blood pressure was 145/94 on several occasions. We're diagnosing hypertension. They say, I don't want to take any medication first. I've been wanting to lose a little weight and I'm wanting to cut back on my drinking. Why don't we try that first? Great. They come in 3 months and their blood pressure is 122/84. Great improvement. Then, and then the patient will then feel better motivated and confident. And Rome wasn't built in a day, and good control of chronic conditions is not built in 1 visit or 2 or 3 visits, unless it's very mild, which, again, we're diagnosing things milder, which is good these days, but no rush. We want the patient to understand why we're recommending the treatments and lifestyle modifications, and we want them to feel confident they can do it, and we want to reward them, and they feel rewarded themselves when they have success. Okay, getting towards the end here. Now, everything I've talked about so far is what your responsibility as an individual clinician is. But we're not alone in this. At Kaiser, I had many resources for this. Other health workers can improve. For example, and I know that in safety net clinics, they're often understaffed and don't have resources, but each one of you can think about, in my given clinic situation, which of these techniques, which of these other other roles can I use to help me with this? For example, MAs can use the electronic health record to identify non-adherent patients using some of the techniques we did before. At Kaiser, I could get a printout of every patient with diagnosis of hypertension who hasn't been seen in a year. That is low-hanging fruit because the MA can call them and say, Dr. Kleinsinger wants to see you. It's been a long time. Can I make you an appointment? Those patients, often, if you get them in, things can really improve. The patients whom we don't see often are the ones who are creating poor consequences, poor statistics, because they're not dealing with it. But if we rely upon the patients having the initiative to come and make an appointment, we're missing a lot of important patients, okay, who need the help. RN case managers, clinical pharmacists can work with non-adherent patients. I've had the experience of doing my very best with a patient, and they're still having adherence problems, and they go see a clinical pharmacist who maybe does similar things to me, but in a different way, maybe reaches out to them better, has a better relationship with them. I don't know. But for some of the patients whom I've been seeing who are not well controlled, they see somebody else and they get much better control. So that, and don't forget LPNs, LVNs. Yes. Yes, absolutely. If any category of other health practitioners you have in your clinics, use them. And so one question I'm going to ask you all, and that person who put that comment in the chat is doing that. Who in your facility can help with this? And talk in a staff meeting. Do you have a staff meeting that works? Bring up these issues because actually my experience is the MAs enjoyed this. They weren't just rooming patients. They got some time to look at lists, to call patients, et cetera, et cetera. They felt important, like they're being a part of the team and doing that. And so use other people to do the research and to reach out to people, et cetera, et cetera. And also the clinicians who can deal with this, like RN case managers, diabetes specialty nurses, clinical pharmacists, et cetera, use them. Okay, we're reaching the summary, okay? Medication non-adherence is ubiquitous and has multiple adverse consequences. Identifying non-adherence is the first step. A multifocal approach. Think of which of these things you want to do is most effective. You don't have to use them all at once. Start with some. Improving non-adherence requires better communication with patients. Communication, in my definition, is two-way communication with using our ears more than our mouths. Teach back, anticipate obstacles, examples. We as a profession have to be accountable for our patients' adherence. It's not on the patient. If it was 1% of patients who are non-adherent, I say, fluke. If it's 40% who are non-adherent, that's our collective group individual responsibility. Since I can't affect how this is being done on a national scope, I can encourage you to do it on your own practice scale and within your own clinic to take some of the steps that will improve this. So again, as I said before, choose 1 or 2 points that you will commit to trying. Again, start slowly, incremental approach, write it down, do it. Taking effective action can substantially improve the quality of your patients' lives and the quality of your medical practice. That's the end of this formal presentation. I'm open for any questions, comments, suggestions, et cetera, et cetera. And at this point, you also could raise your hand if you want to speak too, and turn your microphone off. Okay, community health workers. That's a good point. Yes, if you have access to them, they often, China has the barefoot doctors, or used to. We have the community health workers who often are from very similar socioeconomic and, racial heritage as the people they're working with, have good understandings of people, and they often can be really, really helpful to do outreach to work with people. And someone also said, I have found that patients often tell MAs information they're not comfortable telling their doctors. Yes, that makes sense. And one of the things to ask the MA to do after they've heard that, or anybody else, is say, this is really important information. Well, are you willing to share this with the clinician when you see him or her? Or would you like me to give this information to them? In other words, the MA having the information is valuable, but if it doesn't get communicated upstream or whatever across professions, it often doesn't work so well. What would you say the next step is for patients for whom we have tried everything and still non-adherent? I don't have any magic things about this. The first thing would be to try and understand why they're non-adherent, spend more time. Really check out if they understand the importance of adherence. Really check out the stresses and other interfering aspects of their lives that may be happening. Look for some of those issues that may not be apparent, like the 4Ds of depression, denial, dementia, dependence, et cetera, et cetera. Look for stress levels in their lives that they haven't shared, et cetera, et cetera. And refer to somebody else, because sometimes we're not the right person. And recognize that though these approaches work, there are some patients that we do our very, very best and we can't reach. And, and hope people change over time. If you can establish a good relationship with people. I have found, for example, that with new patients in my practice, that they would listen to what I had to say and were somewhat trusting of it. That if I've been there for a patient over years and I've treated their colds, their sore throats, their, rashes, and I've done a good job and I've been responsive, over time, they may be more willing to trust me on the more difficult issues. So, and in the chat, one helpful point told me by one MP for helping elders with cognitive impairments is to put a Ring camera in her parents' kitchen and help guide her father daily in taking his pills. Communicating over the Ring cam. Absolutely, for people with cognitive impairment, any tools and techniques that we can use. I should mention that because I am somewhat of a national expert on medication non-adherence, I'm contacted a few times a year by people who say, oh, hey, Dr. Kleinsinger, we have this new technique where the patients will get all their pills in bubble packs, and all I do is tear open the bubble pack. What do you think of that? Do you want to endorse that? Et cetera, et cetera. There are a lot of tools, techniques, gimmicks, and the literature on them is not particularly encouraging. The key point is that you want the patient to want it to the extent that you can do that. I don't really know, none of these techniques have been studied particularly well, but if you have access to them and want to try them, I don't have an objection to it. But the key issue here is education and communication.
Well said. And it looks like there is a question in the Q&A. Valerie's asking any recommendations regarding non-adherence related to copays. Straight medical Medicare, people in underserved communities do not have the money for the copay. Some are $40 to $90 for medications.
True generics, hydrochlorothiazide, metformin, the sulfonylureas, most calcium channel blockers and things like that are fairly inexpensive. Any answer to that would depend somewhat on the actual circumstances. Being aware, as people have already, like about for more expensive medications, the fact that the pharmaceutical manufacturers have programs, that would be. Explore every possible option. If you have other people in your clinic with social workers. Oh, I should mention social workers. My wife happens to be a social worker. She's retired too. And so I should mention that I have found that often that social workers in the poverty clinics are often very overwhelmed, but they can help with that, explore possible resources, et cetera, et cetera. But I don't have a great answer to that. Someone put in, I really endorse this. Encourage patient to bring a family member or trusted friend to reinforce recommendations. Absolutely. If the patient has a trusted person who can come with them, and who will, and they have to give permission for this, obviously, and be in the clinic with you, help understand and encourage them. That is a great tool. I should have put that in. I think I had it in an earlier iteration of that, but that is a great point of view. I have to say that a minor concern about that is that in some circumstances, you bring the wife or the husband, and they're going to nag the patient about this, and and you want to be aware of that. How many of you, in any aspect of your life, have people nagging at you, and you say, "Oh, thank you so much. I love being that." Whatever. You want to help them learn to do it in a constructive manner if you can. But I understand that the trusted friend or relative you bring with you is concerned and can get upset, and to a certain degree, that may be helpful for the patient to understand. And that trusted person could then say, "I'm concerned about this," and do some of what we're talking about. Do you understand why I'm concerned about this? And then listen to them, because they can also do some of the teach back and education with that. So I think that's a great point. Any other points? Any other questions, comments, suggestions? I love the suggestions.
I was curious with people in their own practices, with that teach back point. I love the idea of teach back, but also would be concerned about phrasing it in a condescending way. I'm curious kind of how people phrase that so that their patients don't feel talked down to, but we're still getting that kind of feedback.
Does anybody want to answer that? Well, we're running low on time. So the way you introduce any question on a sensitive topic determines the degree of honesty. Let's use another example. A lot of I ask all my patients this, okay? Usually true. That makes people feel they're not being singled out. Non-judgmentally. A lot of my patients have trouble taking medications regularly. That's just the reality. I'm curious, how often do you normalize it? Don't sound judgmental, okay? And so, and then ask open-ended questions and listen. And also when you're explaining things, take responsibility. I used an example of it, I'll repeat it. I often find that maybe I'm not communicating as well as I would like. These are complicated topics, so I want to understand how well I got my point across. Take the onus for it. It's my problem. Did I do a good job? Not how stupid are you that you didn't understand what I have to say? And people don't say that, but that people can implicitly feel being judged, measured in an unpleasant way. Take the responsibility on yourself. I understand this is difficult. Sometimes I'm not as clear as I want to be. It's very important to me that I'm being a good communicator here. Tell me, how did I do a good job? Okay. Is there a program to repackage unused medications to be able to distribute to ones who can't afford it? I'm not aware of that. Years ago, in clinics I worked in, we had a cupboard where we put samples and stuff like that. I don't know how much that's happening these days, but that might be good. But basically, I think the FDA is not really happy about informally, reusing medications. I'm not saying it's a bad idea, and in some circumstances it might be a good idea, but I don't think it happens much. Any other questions, comments, suggestions? Criticisms. How could I have done a better job in this presentation? Is there any aspect of it that you felt didn't work, or I was talking too fast? And I'm not just asking for compliments, so I'm not fishing. But thank you for saying great presentation. Thank you. I appreciate it. Could I have done anything better? And someone's saying charitable pharmacies may be able to repurpose unused medications. Here in Ohio, we can accept patient donations. Great. Being aware of which of those aspects could happen in your location, you could do some research on that. Obviously, it's going to be varied by location. That's a great suggestion. Thank you. Okay, well, so remember, try out anything that appealed to you, start using it now. Any newer data, I didn't update the slides. I'm lazy, but nothing's changed. It's still the same. The studies as recent as 3 to 5 years ago also continue to show very poor national adherence rate to medication. And Sarah has put in some suggestions about other upcoming MAVEN talks. And Scott Abrams, I don't think I've seen Julian's, but Scott Abramson is a great presentation, so I really recommend it.
Thank you so much, Dr. Kleinsinger. Really wonderful presentation, very helpful. And we hope to see all of you soon again, and hope you have a wonderful rest of the weekend.